the Spinal Truth Show, weekly podcast edition. I'm your host, Dr. Caleb Slater, here with
Chris. And you know, I'm really excited to be talking about.
I said your name, I just said it real low.
I heard that. Yeah.
Chris.
But this is exciting to talk about plantar fasciitis.
This week's episode, plantar fasciitis.
If I could talk about it and then talk about it again,
that makes your day.
It's almost like we had a problem with the recording.
Yeah, so we recorded this and then we realized we didn't have the audio on, so.
Which is important when you're doing a podcast, they say.
Right?
So.
Like, it's, first of all, it's what you're drinking during the podcast, how you look, and then it's, you know, can people actually hear you?
Hearing, yeah.
In importance.
It's
Before we start, make sure to like and follow us on TikTok, Instagram, Facebook, YouTube. We are also on Spotify. So plantar fasciitis. Chris, what is plantar fasciitis? Oh, first of all, spell fasciitis. And we literally just did this. So if you get this wrong.
Fasciitis.
Too many TIs, and then it's Fasciitis. Plantar fasciitis. So you got it wrong, and then you got it wrong again.
But there's only proof of it once.
Well, there's proof of it, but it's just you mouthing it.
Yeah, true.
All right, so what is plantar fasciitis to you?
Well, I'm going to play a dumb here because I already know some stuff. But, you know, before having worked with you, all that stuff, I assumed plantar fasciitis was a foot problem that athletes got. And from my understanding, it feels as though you're walking on glass.
Yeah, and that's the telltale symptom of plantar fasciitis. You get out of bed in the morning, and the first few steps specifically feels like you're walking on glass. And we'll get into...
Oh, it's just the first few.
Yeah, because after you... So plantar fasciitis is an irritation, specifically an inflammation of the plantar fascia. Fascia is that white, thin connective tissue you see on raw chicken, raw steak. We have the same thing, runs from the tip of our head to the tip of our toe, surrounds our muscles, tendons, organs. That's your fascia, right? Kind of like the saran wrap to everything holds your stuff together. Mm-hmm. If you put too much force through it, it could tear or become irritated. When you rest at night, those tears heal. Mm-hmm. But if they don't heal fully, when you get up in the morning and you put weight through it, and when you put weight through it, you're stretching the bottom of your feet, mm-hmm. Those tears tear again. That's the sensation of like walking on glass that you get, but once you've retorn them, they feel a little bit better. It's actually kind of like when you sprain your ankle. Like if you sprain your ankle enough times, spraining your ankle again doesn't really hurt as much.
Gotcha.
Similar in notion here to that plantar fasciitis, theoretically speaking, right? So you get up in the morning, you tear it again, you're tearing it kind of throughout the day, here and there, you rest at night, it repairs, but it doesn't repair fully, so you do it again, and it's that cycle over and over and over again.
And so the cure for plantar fasciitis is to just let it rest and heal properly?
That's a treatment for it, and that's why they recommend the boots, so like the night splints. Mm-hmm. It keeps your foot in neutral or a little bit, we'll call it dorsiflected position, so it keeps the fascia on stretch, so that way when it heals and repairs in a stretched position, so that way you don't re-tear it in the morning.
Okay, so if I'm diagnosed with plantar fasciitis and I wear my boot and it heals, then my plantar fasciitis is done and I should not have to complain about it anymore.
There you go.
I'm healed.
Guess
cured.
How often the boots work?
Probably pretty rarely.
Probably pretty rarely, and there's two main reasons for it. One of them has nothing to do with your back.
Get out of here.
Get out of here, right? One of them is patient compliance.
Oh, they just don't want to wear them.
They don't want to wear them.
Is these the big black
boots? Yeah. They're better now. They're less cumbersome. But there's a bunch of them out there. So like some of them that go like all the way up your calf, and they're more, I don't know, intrusive.
So I've seen, because my kids dance and sports and stuff like that. Usually, who I see wearing these big black boots are like either teenage athletes.
That they're
or something.
not putting weight on it.
Yeah.
So you might be talking about like a platform shoe.
Yeah, maybe
where
that's something different.
Like you broke your toe, you don't want to.
Okay, it could be something different like that. Okay.
But it's typically it's a big black like ski boot looking thing.
And you have to sleep in it.
You have to sleep in it.
Do you walk around in it as well?
You can.
Okay.
But it's mainly for sleeping.
Gotcha. So you wear that every night or just?
Every night for a while. Because remember, you have to, like, this tissue has to heal. It has to heal in the elongated position. It takes a little while for this tissue to heal, you know.
But
Most people won't sleep with it. It just gets in their way. It's hot. It's uncomfortable. They don't like it. But one of the reasons they might not like it is, so, if you're following us, you know that we're very spine-centric, and you know it's for a reason. I've done all the typical treatments, and we'll talk about the typical treatments for plantar fasciitis. We'll talk about what else it could be, but one of them is if it's not plantar fasciitis, if it's not pain in your foot, where could the pain be coming from? Your back. Specifically your sciatic nerve, right? Well, one way to irritate the sciatic nerve is by stretching it. One way to stretch the sciatic nerve is by keeping your foot in a dorsiflex position. So
you're making it worse.
A lot of people are like, no, the boot just made me worse. Well, yeah, the boot made you worse because you have a nerve issue.
Yeah.
There you go. So a lot of people out there, especially if it's in their right side, they feel like driving aggravates it. Driving doesn't aggravate your plantar fasciitis. Driving aggravates your sciatic nerve.
Gotcha.
Thank you for watching the Spinal Truth Show. I hope you're finding this information helpful. If you're out there and you're still in pain and you're looking for relief, we have some solutions for you. You can schedule a consult with me or a session, but if that's not in the budget, we also have some options that are self-guided at home. You can go to thespinaltruth.com. We have courses set up right now for arm pain as well as for neck pain. They are geared towards you. They are a 4-week course, 60 videos that are self-guided by an expert in the field that you can do from the comfort of your own home at your leisure. They will take you through step by step the typical approach that I take with patients. The expectation is that they will provide significant relief over these 4 weeks. So if you're looking for something better, something different because you're not finding the relief, go to thespinaltruth.com, sign up for one of these courses, and get the right treatment, see the difference.
All right, well, before we get into specifically the treatment and what you think a lot of the pain is actually coming from or the problem is actually coming from, is there ways to rule out plantar fasciitis that it's not coming from your foot fascia?
Never completely, but there's ways to be much more certain.
Well, can you get plantar fasciitis on both feet?
Again, you can, but it'd be more likely that your symptoms are coming from your back.
Right.
So that's one of the signs, right? The more clear sign is if there's numbness or tingling. So plantar fasciitis is an irritation of the fascia. There's no reason that you should have numbness or tingling, which is basically only because you've irritated a nerve.
Gotcha. Because that should feel more like pain instead of...
it could feel pain. Yeah, well, so an irritated nerve can be painful.
Right, but not
But an irritated nerve can produce numbness or tingling. An irritated fascia can be painful, but it cannot produce numbness or tingling.
Gotcha.
So if you have numbness or tingling anywhere in your leg, you do not have plantar fasciitis. There you go. Like that one's pretty absolute.
Okay. What if you just have like pain in your your little toe or something like
yeah, so it's not the same as carpal tunnel. Yeah. I mean, so for plantar fasciitis, it's typically more towards the heel / midfoot.
Gotcha.
There's like where the fascia kind of inserts. But anywhere pain on the bottom of the foot, you can make an argument for plantar fasciitis.
Okay. Is there any other?
So if it's outside the bottom of your feet, right? I see this a lot, and you'd be surprised. Like people also have pain in their calf or in their shin or up their leg as well, and they're like, well, it's just because your foot hurts and you're walking funny. They'll explain it away like that. Like no, like if you have pain outside of the bottom of your feet, outside of where your fascia is, you do not have plantar fasciitis. Another one is rest. If you're just resting, if you're just sitting there, if you're just lying down, and you get your foot pain or your foot symptoms, it's very likely not from the fascia. The fascia is a connective tissue. It's the connective tissue at rest doesn't really do anything unless you're stretching it, right? So if you're just at rest and you're not moving your foot, most of the time your foot is in actually like a rested plantar flex position, which shortens the plantar fascia. So if that's the case, you shouldn't have any symptoms whatsoever.
Right. Is there an imaging that can be done to see if your fascia is torn?
Yes, you can do ultrasound. I mean, you can do CT and MRI. I feel like it's more likely in the foot though that they'll do an ultrasound. But your fascia could be torn and not have any symptoms whatsoever.
Okay, so that was going to be my question. So if it's from my sciatic nerve problem, and I'm feeling these foot symptoms, does that mean my fascia is torn, or could it just be from the sciatic nerve?
So it could
Or both.
It could be both.
Gotcha.
Right? But where to start? And for me, again, we talk about this a lot. If you come in with foot pain, I ask you about your foot. I look at your foot. I ask you to move your foot. I touch your foot. I see where the problem is, where your symptoms are. But then before we do anything, I look at the correlating area of your spine. I look for stiffness or pain, specifically to palpation. Me touching it, putting pressure on it. I look for your inability to move or to compensate in the area. And if I find any of that, we treat it, and then during that same session, we see if your foot symptoms changed. And often that's the case. And now you're like, okay, well, at the very least, there's something from the back attributing to your foot pain.
Gotcha. We talk a lot about your thoracic spine, which makes sense why it causes a lot of issues with today's lifestyle, with everybody being hunched over all the time, seated, working at a computer, looking at their phone. But your sciatic nerve, when you're seated, aren't you in a flexion position instead of extension?
So you could be in either.
Okay.
Yeah, I actually think most people these days are more in an extended position sitting than they are flex. And we used to think the opposite, I should say we still do think that when you're sitting, you're in a lumbar flex position. But I have a few reasons why I don't think that's the case anymore. One of them being, when's the last time you sat in a chair, like an office chair, that didn't have good lumbar support?
Yeah.
Okay, even cars.
Yeah.
Right? Most cars, even if they're not, like it used to be just the higher end cars, your Mercedes, your BMW, if you got leather seats, they would come with some lumbar support. Now, even if they're not electric lumbar support, it's still built into the chair. Mm-hmm. So pretty much every chair that you sit in keeps you into, it's called lumbar lordosis or extension for your low back, right? Additionally, I think we've actually changed our spines a little bit over the last 2 decades. And what I mean by this is that we have dramatically become a more sedentary society. I mean, if you think about it, back in the late 1990s, there was still a lot of companies, high-end companies, or big-name companies that didn't even have a website, a URL. We were still betting that the internet might not stick around.
Yeah.
Just put it that way, right? Computers, specifically, computers were around, but they weren't nearly as ubiquitous as they are these days, right? The first iPhone came out in 2007. So if you think about that, that's 18 years ago. Think about how, up until then, I never had a BlackBerry or anything like that, but for the most part, there wasn't a lot of reason to look down at your phone because your phone was mostly just a phone. Now,
good old days.
Yeah, now all of a sudden in the last 18 years, your phone is your camera, it's your media studio, it's your
social
TikTok,
life.
it's your social media, it's literally, it's your calendar, it's everything. It is everything in one, and we look down on it, and what that does, so how does that affect your low back, right? Well, what it does is it really rounds your upper back. So if my upper back is now rounded and stiff, which is the case for pretty much all of us, if I want to look up and I can't really do it at my upper back, I have to achieve this at my lower back. And so I actually think a lot of people compensate with their low back and they keep it extended. The chairs keep it extended. When you walk, when you run, your low back's an extension. When you sleep, when you lie down on your back or your stomach, your low back's an extension. So if you're pregnant, your low back's in progressive extension, specifically over the last 5 to 6 months of your pregnancy.
So we need to get some flexion.
You need to get some flex. And this is what I see often takes away the patient's symptoms into their feet. So we're still talking about plantar fasciitis.
Yeah.
All right, so if you're out there, you've been diagnosed with plantar fasciitis, a few quick ways just to kind of recap, a few quick ways of knowing that it's not plantar fasciitis if there's numbness and tingling. Absolutely not plantar fasciitis. If you have it on both sides, it's much less likely that it's plantar fasciitis. If you have it at rest, it's much less likely that it's plantar fasciitis. If it comes and goes, sometimes it's there, some days it's not. One day it's good in the morning, the next day it's not. That's more likely a nerve issue, not a fascia issue. If it's been going on longer than 30 days, now it's at the very least not plantar fasciitis, an inflammation issue. Now you like plantar fasciosis, fasciopathy, stuff like that. So at the very least, the terminology's changed, that it's not an inflammatory condition anymore. Now it's a chronic condition where the tissue's different, compared to an inflammatory issue.
If it's going on for 30 days and that fascia hasn't healed properly, right?
It's then it's more likely a nerve issue, right? Yeah. If you're getting treatment to your feet and it's not working after 4 to 6 weeks, and working means somewhere around 50% improve, you should be thinking like, I go to therapy or I get this treatment and it helps. It doesn't just help for a day or two, it helps, and I keep feeling like I'm getting better and better, right? So slowly over the course of 4 to 6 weeks, you should be like, yeah, like it was 10%, now it's 20% better, now I'm getting closer to 50%. If that's the case, great. If not, you're probably getting the wrong treatment or to the wrong area. And for most people that have plantar fasciitis, the treatment is the same. It is rolling it on something and stretching it.
What about shoe inserts?
Yep, so shoe inserts or orthotics. And again, I talk about how I've done all of this stuff in my career, and I just found it wasn't as helpful as I wanted it to be, so I kept moving on. I kept looking for something different, and that's ultimately what led me to this spine-centric approach. So when I say, like, I've done shoe inserts, I spent years where I'd fit patients for these inserts, and I talk them through, how to use them and what to do, how to break them in, and how they fit well and how to get them into different shoes, and really go through the nitty-gritty components of inserts. And then even recommending patients to go and get custom orthotics, as well as doing taping, supporting the arch or taking some pressure off of like the heel for the fat pad, whatever. Like,
what about the ball, like rolling in the ball?
Rolling it on something is what, so I've had patients do that. I've had patients stretch it. I've done graft into the area, which is me taking a metal tool and like scraping the fascia.
It's like a Klingon battle weapon.
It hurts. Yeah. It doesn't feel good. I've done ultrasound and iontophoresis. I've done short foot strengthening. I've done low load, long duration stretching.
Well, okay, so say you do all that stuff. There's got to be a portion of the population who, after 30 days, their symptoms go away, and I assume that's probably because it actually healed. And
yeah, it can be, but you also like, have you ever had back pain?
Or you just get used to it.
Yeah. You've had back pain in the past?
Sure.
Do you have back pain now?
I have some stiffness and stuff.
But do you have back pain now? Would you say, if
No.
I walked up to you and like, hey, do you have back pain?
No, I'd say no.
Okay. What did you do to make it go away?
Well, I moved on with my life.
Yeah. No, seriously though, right? Like,
Yeah.
it pretty much, you didn't do any formal treatment, right? It just went away.
Yeah.
So I'm not saying that the treatment at the foot didn't do anything, but I'm also saying that your back symptoms could have just kind of temporarily went away.
When we were talking about carpal tunnel, there's an element of data that you could gather during the diagnosis phase where you could do a grip strength test. And you could see a specific number, do an exercise or two, and see if it affected that. Is there something like that you can do with your foot?
Yeah, so it's a good question. And the goal of the eval is to find that, right?
Yeah.
For most people, it's like going up on their toes, so raising their heels up off the ground, or walking. So you just have a patient walk and you're like, all right, when you walk, how much does it hurt? Where does it hurt? Is it every step? You try to put as much objective data onto those subjective symptoms, right? Have a patient go into a deep squat or go up and down stairs.
And measure.
And ask them about their symptoms. For the plantar fasciitis, unfortunately, most of it is putting them into a position or a movement and asking about their subjective symptoms.
Gotcha.
You're trying to reproduce it right then and there. Those are probably, again, raising your heels up off the ground, going up and down stairs, going into a deep squat, or walking, specifically maybe walking fast.
Okay. Now, we're talking about plantar fasciitis, but there is some other foot diagnosis, like Morton's neuroma.
Morton's neuroma, metatarsalgia. So those are in the forefoot. So that's how you would differentiate them between plantar fasciitis, which is more in the mid-foot to heel.
Do they both cause kind of similar pain? Or
similar, yeah, pain on the bottom of the foot.
And would you say that your treatment or the way you would diagnose it is similar or the same?
I would do pretty much exactly the same as I talk about.
Okay.
Look at the foot, map out the foot, touch the foot, but then look to the back. But all of what you just described is innervated by the sciatic nerve.
Gotcha.
In one way or another. It's the medial plantar nerve, which is a branch of the sciatic nerve, but whatever, it's innervated by the sciatic nerve. Hey, just a quick break here and then we'll get back to the show. If you're out there and you want to see if this is the right approach for you, you can schedule a consult or a session with me. Go to thespinaltruth.com. At least set up a consult within 30 minutes. I will listen to your symptoms. I will go over your history. I'll go over what the approach I would take for you and the results that I would expect. My goal is to save you from continued pain, failed treatments, and prevent you from getting surgery. So go to thespinaltruth.com, set up a consult, and let me go over your symptoms. Now let's get back to the show.
Okay, so before we get into treatment of the sciatic nerve, we talked about a bunch of the different things that you would do for the foot. Does it ultimately, if those things aren't effective, does it lead to injections and surgery?
Yes.
So every road leads to surgery.
Well, all right, and here's a fun. How do you know how they treat carpal tunnel, right? We just did the podcast.
Yeah, they make the tunnel bigger.
Right.
Yeah.
Okay. How do you think they treat plantar fasciitis surgically?
Well, since it has to do with fascia, do they just reattach surgically repair the fascia?
That is what you should think.
But it's not.
They do what's called a fasciotomy.
They remove the fascia.
They cut the fascia.
So it's no longer effective.
Useful. You can't stretch it. You can't irritate it anymore when you walk on it because it's already
gone.
It's already too stretched.
Oh, so there's no tension left.
Yeah, it'd be like you can't rip your shirt because I ripped it.
Gotcha. So you get the surgery.
It probably doesn't help.
Would it not even temporarily relieve pain?
It might, but that is one that there's some surgeries like carpal tunnel. It's not that bad if you get your carpal tunnel repair. Even if it doesn't work, not a big deal. This one, it's like, no, I don't want that. I don't want you to release my fascia.
And what does the recovery look like for that?
It's another quicker recovery.
Okay.
Yeah. So.
But that's terrible. You go through all this, you do the billion different things, still not working. You get the injections, which maybe temporarily relieves pain. Then you ultimately get a surgery that really didn't help either.
Yeah.
And then what? Then this is it.
Then this is it. You kind of live with it.
You live with it.
Yeah. And all I'm saying, so and again, I always have to qualify this. I'm not saying that there aren't people out there that have plantar fasciitis, but what I am saying is that a lot of people that get diagnosed with plantar fasciitis do not have it. They are misdiagnosed. And if that's the case, it's very likely coming from their back, and it's treatable. There you go.
Yeah, it sucks because of going to a doctor and you say you have a foot problem, they're only going to look at your foot.
Pretty much.
But knowing what you know with your experience, that you can see all these symptoms be coming from a different area of your body, and that area never looked at.
And that area is rarely looked at. Like if you have foot pain, so a lot of people out there, and I think you were kind of getting to this on a different episode, where you're like, well, what if I don't have back pain, but I have pain in my foot? Yeah, you don't have to have back pain to have a back problem, okay? And your symptoms also progress. At a certain point, the pain that you had in your back, you get used to. Either you compensate for it, you don't move as much in that area, or you just get used to that stimulus. You get used to that pain, and you process it now as your new normal, right? Mm-hmm. And as that problem stays there, it evolves. And as a local back pain gets worse, it puts more and more pressure on the nerve. That more and more pressure on the nerve typically sends symptoms wherever that nerve goes. And if it's one of the nerve roots for the sciatic nerve, it's wherever the sciatic nerve goes, which is anywhere in your leg for the most part.
So would it be common for people to have had knee pain before they have plantar fasciitis or anything like that?
Yeah, so it's a really good question. Often they do. Often they're like, oh, it's always this side. This is the side I had my knee pain on, and this is the side I had my hip pain on. And yeah, it's because you have a nerve issue that's on that side of your back. There you go.
So I've laid in bed before, and I've had a stabbing pain in my toe. Yeah. And I'm like, oh, that's probably just early diabetes or something like that I'm dealing with.
Right, or you'll think it's, what's the one where you have too much uric acid? I'm blanking.
Yeah, I don't know what it's called either. I know what you're saying though.
It's not rich man's disease. It's come on.
I don't know. But either way.
Yeah.
I don't think I have I give my blood test. I have to clean all. But But I've had that stabbing nerve thing in my toe before.
Yeah.
And I've had knee pain before. And so I'm probably one of those people who probably should do something about their sciatica.
Probably. But you won't do it until it's
Till
bad
I'm
enough.
like so bad that like, fine, I'll get my fat butt up and do something.
And then you have to hope that you get the right advice.
Hope that I get the right advice. But I know now, like,
Gout.
what?
Gout.
What? Gout. Gout. Yes, gout. I don't think I have gout. But it makes, like, yeah, we're all living our lives. Once thing gets to a point where you can't avoid it, and that's when you.
Yeah, and I actually I write that in my book, right? Like I say, I have 2 chapters that talk about the medical system as it stands and you know what's going on with it. And one of them, it starts by like, all right, you have pain. What's the first thing you do? You ignore it, right? You're busy. You're at work. You have kids. You have a house. You have a spouse. You try to have a social life. Plus, if you ran to the doctor every time you had a little ache or pain, you know, you'd be going to the doctor all the time and paying copays and scheduling, and it's all just a logistic hassle, right? So it makes sense that the first thing that you do is ignore your symptoms and see if they persist.
Yeah.
Which is what everybody does. But then by the time you realize that it is persisting, by the time you schedule your doctor's visit, by the time you get into your doctor, by the time they refer you to a specialist, by the time you get into that specialist, so that's about the time that you get some imaging and they give you your options, which is injection, surgery, or physical therapy. Those are like the top 3, right?
Yeah.
And you pick typically injections or physical therapy first. Maybe you do the injections, you wait a little bit, it's still there, and now you do the physical therapy. By that time, if everything goes well, it's like 3-4 months down the line.
And thousands of dollars.
Probably not thousands, but it depends on your insurance and stuff
and all
like
that
that,
stuff,
right?
yeah.
But it's a lot of hassle. I mean, it's at least
Time away from work, time away from your family.
You know, it's probably at least 3 doctor's visits. You know, your primary, the ortho, and then let's say to go get the imaging. So that's at least 3. It's probably another one to go back to have the imaging explained to you. So 4. So now you have 4 doctor's visits. You know, copay's $50. Your time off of work and stuff like that. So.
And ultimately, you didn't get any help.
Ultimately, there was no treatment provided.
Yeah.
They just ruled out some things, which, again, just by talking to you, could be really feasibly ruled in or out.
So, all right. It's pretty obvious to me now that there's a couple things that we could do for our back just to combat the lifestyle that we currently have, most people currently have.
Yeah.
And it's mostly dealing with your thoracic spine and then dealing with your sciatic area, right?
Yeah, so you could break the back into 3 different areas. You know, your cervical, so your neck, your thoracic spine, which is your shoulder blade area, and then your low back, which is your lumbar spine.
Okay.
In general, your thoracic spine, it makes sense that, you know, we're so forward rounded that the treatment is getting you out of that position. So if we're already flexed, it's extending it, right? For our neck, we're so protracted. We're like our chin's out, we're looking forward. It's typically like retraction and extension. Again, it kind of just makes sense. You're just doing the opposite of what you're doing all day long.
Yep.
For your low back, it was commonly thought that you're in flexion, but again, I kind of think that you're more in extension, especially the way we are these days, than you are in flexion. And I see people respond for hip pain and knee pain and foot pain. I see them respond by flexing their back.
Gotcha. All right, so if you're out there, is there a difference if you're out there listening that you have some foot pain or you have been diagnosed with plantar fasciitis and you went through all these treatment options? What would you say to these people? Is it the same thing? Meaning someone who's just kind of starting on a foot pain journey and someone who's been on it for a while and tried a bunch of different things?
So for me, yeah, the one that's been on it for a while, it's more likely it's their back.
Sure.
Right? The treatment they were getting wasn't helping. It's been past 30 days, so it's not an inflammatory condition anymore. But for me, they're both the same. I would evaluate them and treat them both the same. You map out their foot, you look at their foot, you look at the movements, you try to reproduce their pain, but then you look at their back. If you find anything, and anything also means like on the subjective. If they're saying stuff like pain at rest, pain on both sides, numbness and tingling, that means that you probably treat the back and see if their symptoms in their feet change.
Do they do, I know with carpal tunnel, they do a nerve test to see how
It's much less common.
Gotcha.
Much less common to do like a nerve conduction velocity or EMG for the legs. I'm honestly not quite sure why. I think we just rely more on imaging the back. But we've talked about how imaging is more misleading and accurate than most people realize. I was going to say something about the treatment itself for the feet. We talk a lot about inserts and foot stretches and stuff like that, and I don't think people realize too that inserts are basically a crutch. Like your foot is supposed to be mobile to a certain extent. When you put weight through your foot, it expands. Your muscles need to contract in order to support it and move it. But when you put it into an insert, you're basically putting it into a splint or a cast, for lack of a better term. And now that foot can't splay out like it's supposed to. It's harder for certain ligaments and muscles don't get stretched or moved into a natural position. It's harder for you to get that foot contraction. So it leads to a stiffer and weaker foot. So you might think like, hey, these inserts, they're the only things that are helping me right now. Like they're helping you right now, but they're hurting you down the line.
Yeah, that makes 100% sense. If you use a crutch and you're not using your muscles and stuff, when you go to use them again, they're going to be much weaker. And
Yeah.
Yeah, so yeah.
You picture like having a back brace on and like, oh, the back brace is really helping me. Great. But do you want to live like that forever?
Yeah, and is the back brace permanent now?
Right. And most people would say no. Like, of course not. Like, I want to work to improve my back and strengthen it so I don't need the brace. But we don't have that same mindset for the inserts. We find an insert that we like and we're like, oh, this is forever now.
Yeah,
or we find a shoe that we like. People say, what's the best shoe? There isn't a better shoe. The best shoe is a strong and mobile foot. There's some shoes that might be better temporarily, but you should never resign yourself like, oh, well, I guess I just can't wear heels anymore. I can't wear this certain shoe anymore. I can't wear flats anymore because of this.
I feel personally attacked right now. I put my Vans on the other day and I stepped and I was like, oh, I can't wear this shit.
Can't wear that anymore.
Like these are like walking on cardboard. Like I love them, but yeah.
And there's a lot more to say about like the foot itself to do some things, but again, the point of this is that changing your shoe, changing your inserts, that's not treatment. That's just managing your symptoms.
Yeah. All right. So they're out there. They got foot pain, or they've already been dying. What should they do? What should someone do?
Well, all right. We have a plantar fasciitis series that's free. It's on YouTube and it's also on our TikTok page. If you go to our homepage and you go to the playlist tabs, which nobody seems to know about,
they're there.
They're there. You can scroll through them. There's a plantar fasciitis playlist. It quickly takes you through a lot of this information, what is and isn't plantar fasciitis, how it gets misdiagnosed, and then it offers some movements for you to do in order to see if it's your back.
Gotcha.
If you want more than that, you can schedule a consult or a session with me. You can go to thespinaltruth.com. I'll go over your symptoms. I'll give you the best guidance that I can. If it's a consult, if it's a session, we map out your symptoms, we map out your movements. Then we treat the back, and then we see if we changed your symptoms, and then we go from there.
So there is options out there, and to me, it's the treatment in your sciatica, that area. It's just like you should be doing that anyways, almost like most people.
I think I've said this a few times now, but there's a few things that should be kind of taught in school, and one of them is a Jefferson curl. Jefferson curl, foam roller, chin retractions. Honestly, you do those three things, it's better. It will keep your spine much healthier than if you didn't do them. And it combats the negative stuff that you're doing all throughout your day.
Yeah. And they're not difficult. They don't take tons of time.
No, and they're also not just managing your symptoms, which again, you talk about all the treatments that we have for let's just stick with plantar fasciitis. Any type of taping, it's just temporary, right? I mean, it might feel good in the moment, but once the tape's off, you're back to where you were. You didn't change your foot at all. Any type of like Graston or massage or any type of hot pack or ultrasound or any of those modalities, laser, that's pretty much just temporary, right?
Yeah.
Stretching, you can make an argument, but in general, like we talked about, when you walk, you stretch that area naturally, right? So When you walk, specifically when you walk quickly, so when you take a longer step, you stretch your foot, your fascia, your Achilles tendon, the muscles in that area, they're stretched naturally. So if stretching was the answer, walking would be the answer.
Yeah.
Right? The biggest take home is if you've been doing treatment for 4 to 6 weeks and you're not seeing significant improvement, it's time to not only start to rethink the treatment, but it's time to rethink the diagnosis itself. And spend a little bit of time troubleshooting the treatment, try something a little bit different at the foot if you want, but at a certain point, it just makes sense to consider the back, consider the spine component. And by the way, I see this often. This isn't like, oh, hey, it's a rarity, like you're the special person. Like, no, you're the special person if you actually have plantar fasciitis.
There you go.
Look at that.
We did it.
We did it. All right, that's our show for today. Hopefully we gave you some information that you didn't have. We kind of gave you a different way to look at your body as a whole. Maybe some hope if you're out there and you have some plantar fasciitis or foot pain symptoms and they're not improving, something to do. If you would like a consult, you can go to thespinaltruth.com, set up a consult or a session. You can look for our plantar fasciitis playlist on YouTube and TikTok. And keep following us for more information, more of what the medical system can get wrong and what can be done to make you feel better.